where they saw EMS negatively was the EMS took control away and never gave it back, never included the family members and the patients in the decision making, never helped them to understand what was going on. So there was this real sense that now I've lost control over my life. Now these strangers come into my house and take even more control away from me. That's creating even more stress in my...
Hello, everyone, and welcome to the Bedsides and Boardrooms podcast. This is our very first episode, and we are excited to have Dr. Caleb Gage as our first guest. Thank you very much for joining. On the Bedsides and Boardrooms podcast, we speak about the intersection between medicine and business and how those two sometimes come together and how they sometimes clash. So we're very happy to have you on the podcast, and we're excited to discuss what we're going to get into today. So thank you very much, and thank you for joining.
Thanks for having me.
So just to start off with, can you give us just a little intro on yourself and tell us about what you do in your career?
Sure, yeah. So I am a paramedic by profession. I currently work at the City of Johannesburg EMS at our training academy. So I'm a program manager here. And then I'm involved in a lot of other projects around the country. One exciting thing to mention, I suppose, is I've gotten involved with the Stroke Angels, if you're aware of them. I'm sure you are. So I'm sort of their national EMS coordinator. And then I'm obviously involved in Proficient as well, working on that project, which is quite exciting. And then I suppose on a more personal note, I'm married with 2 little boys that keep me really busy. They're 4 and 2 years old, so life is busy, but I love them to death. And then also I'm a Christian, which is probably important to say, since that influences a lot of what I do, everything in fact. So yeah, that's basically me in a nutshell.
Yeah, and I think that aspect of religion is going to come into what we're going to discuss a little bit later on. But you studied, like we can just go through what you studied, but we were, I think, a year apart, I think a year ahead of me.
Yeah.
But just go through what you studied and how that has kind of shaped your career later on.
Sure. So yeah, we both did the bachelor's degree at the University of Johannesburg many years ago now. So that was the 4-year bachelor's degree for that. I then went on to do the Master of Philosophy at the University of Cape Town, which you also did. So that's good. And by the way, I mean, I highly recommend that course. I mean, that program is really what launched me into where I am now. So I really, for any EMS, emergency medicine providers out there, I highly recommend it, because it really, for me, it expanded my horizons. I mean, up until that point, I was thinking primarily just about clinical care of the patient in front of me. And then that course just sort of opens it up to, healthcare systems, health economics, thinking about where EMS, for example, fit into the broader healthcare scheme of things. And so it's really fantastic. So I highly recommend that. And then it was on that course that I performed some research involving palliative care and EMS. And then I took that further, also at UCT, to do the PhD program there as well. And that's how most of my research ended up around EMS and palliative care.
Yeah, I think the way that you speak about the MPhil program, but I really found, especially in that time of my career, I just graduated. I think I was a year after graduating, then I started the program. And yeah, no, it does really just open up your mind to different aspects of the way that different healthcare systems are integrated. And I think, when you're looking at sort of the business aspects of how medicine and business kind of come together, really does open up your eyes to, we're just so focused on clinical management and the management of patients, whereas there's actually a whole bunch of other things that go into, how a patient gets treated. So,
Yeah.
yeah, I think
And I mean,
I
that is
echo that.
important, right? I mean, the clinical aspect remains incredibly important. But it really does just show you how much more is out there to learn. Yeah.
Yeah, I always think that is treating the patient right is just the very first step. And after that, there's a whole bunch of things that go into uh, making people healthy, which I think
Yeah.
is very interesting to consider. Your PhD was focused around palliative care, which is an aspect of care that is maybe not, I wouldn't say as glamorous. We obviously do a lot of palliative care cases for patients that are sort of towards the end stage of life. For those of you that are not part of the medical field, palliative care is end stage treatment of patients that are towards the end of a terminal disease. And it's about treating a patient that is no longer, we're trying to treat the cause, and we're actually trying to treat the symptoms. So maybe if you can just go into what is palliative care, but also what drew you to research in that field.
Yeah. So it's definitely palliative care, I suppose. Yeah. It's not as glamorous, and yet it can be so rewarding um, when it's done correctly. But I think part of why it's not glamorous is because it it's misunderstood. So I'm glad we get to talk about actually defining what it is. There's a lot of myths surrounding it, a lot of misunderstandings, and also it's hard. Palliative situations are incredibly emotionally demanding. They are incredibly taxing mentally because they are very complex situations. And the decision making that goes into these kind of situations is incredibly difficult. So that's perhaps why it's not as glamorous. I sometimes think, in the EMS, we think we've seen some things, we have experience with these difficult situations, but palliative medicine, man, I don't know if I would have the capability to be a full-time clinician in that field. I mean, it is tough.
Yeah.
But just to, go into what it is, I would describe it as, there's a WHO definition and all these things, but they use a lot of words and it's very complicated. But basically, it's holistic comfort care for patients with life-limiting illness. And the aim is to improve quality of life and relieve suffering. And that is done, as you mentioned already, through symptom management primarily in terms of the physical. However, it is also holistic, right? So it also involves more than just the physical symptom management. It's also, we're talking the cultural, social realms. We're talking about the psychosocial realms. We're talking about mental emotions. Every aspect of what makes up a person, palliative care is there to help bring comfort to and relieve suffering and improve quality of life. So certainly, as you alluded to already, palliative care includes end stage, end of life, but it certainly moves beyond that. So it's not just limited to that. I think, most of the time people think palliative care, it's end stage cancer. And certainly it's included there, it's valuable there, it's necessary. But also think about patients like COPD patients who continually worsen, struggle to breathe. Think about a child with debilitating cerebral palsy. There are children with rare genetic diseases which cause continuous seizure activity, and that can happen through their whole lives. So palliative care can also be with someone for their entire lifespan, and the lifespan can be a normal lifespan. So it might be helpful to just dispel some of the other myths around palliative care as we start the discussion, just so we're clear what we're actually talking about. It's not just for cancer patients. That even in the medical field, that seems to be the primary understanding of it. is that it's just for cancer, but it's certainly well beyond that. I mean, you look at the non-communicable diseases that we have here in South Africa. I mean, you've got huge cardiovascular disease, respiratory illnesses, not to mention the burdens and morbidity from HIV and TB and these kind of things. So all of those patients end up with palliative needs at some point. And so palliative care is quite broad. And the other thing is that it is holistic. So as we mentioned, it's not just the physical, which is quite an important aspect of it, and one of the things that actually drew me to it. There are some other things, for example, the topic of euthanasia comes up, and that kind of scares people away from palliative care. But essentially, palliative care doesn't really have anything to do with euthanasia. It's a separate discussion, which I think we will probably get to. But palliative care itself is not really interested in the length of someone's life. So it's not interested in prolonging it. It's not interested in shortening it. It's interested in the quality of life of the time that someone has left. So that's really the primary focus: quality of life, relief of suffering. So yeah, I think that gives us a good broad understanding of what palliative care is. So in terms,
So let's,
yeah,
when I say palliative care is maybe not glamorous, what I'm meaning is that as healthcare providers, we often are trying to treat a patient's condition and ultimately want to cure them of that condition. We want to get that disease gone and we want to fix whatever issues that there is. But whereas with palliative care, we're not treating the cause of the problem, we're actually treating the symptoms. So if you can, maybe just go into some of those aspects of treatment that are not curative.
You're so right. I mean, it's also very much an EMS provider mindset, right? This curative care. I mean, that's all that we're trained in. We have to cure the patient. We have to treat the illness. We have to save the life. The unspoken rule is that no one dies in the back of my ambulance, kind of thing. That being said, palliative care, the supportive nature of palliative care, is also not opposed to curative care. So I think this is also one of the misunderstandings, is that palliative care doesn't mean that we've given up on curative care. In fact, the research is very clear that the earlier in the disease trajectory that palliative care is initiated alongside curative care, the more effective the palliative care. So the two definitely are meant to go hand in hand. But because we are often focused on the end stage of a disease process, as the trajectory develops, curative care, and the patient deteriorates, the curative aspect does play a lesser and lesser role, and the palliative care starts to take over and play a greater and greater role. But the two are certainly not opposed, and they're hand in glove. At least that's how it's meant to be. So yeah, just to give an idea about that, sort of the more holistic management, if we take that example of let's say a late stage lung cancer patient where curative care has been stopped. The decision has been made that chemotherapy, radiation, these kind of things are not going to help any longer. There's definitely the physical symptom management side of it, because those patients will be in a lot of pain and discomfort. They'll be struggling to breathe. So morphine in that patient is going to play a major role. But if we think beyond the physical sort of symptom management and medications and so on, there are other aspects to that person's life that we want to help them with. This is a great example of why we call it a life-limiting illness, right? Is because you cannot live your life anymore. There are certain things you are prohibited now from doing. So what can we do to make this patient's wishes happen? I saw a nice example of that was, some of these patients want to go watch a cricket match. So the service comes alongside them, takes them to a cricket match, monitors them and treats them while they watch the cricket match at the stadium, and they get to take part in that, give,
Like
some
a
joy that they want
Make-A-Wish.
to experience. Yeah, exactly. Like that Make-A-Wish. Yeah. And so those kind of things are incredibly important. The other aspect of palliative care, and even in this kind of situation, is the family. Because this is the other thing that the sort of the typical, at least EMS mindset, is that we're just focused on the patient, and we actually sort of chase the family away. Like those
Mm,
professionals that work here don't get in our
mm,
way, um, which is terrible because the family is also suffering through this. Watching a loved one suffer. If you've ever experienced that yourself, you'll know how taxing that is, and it has been described as one of the most stressful um, human experiences in existence. So watching a loved one suffer is itself suffering. And so palliative care also takes families into account. And that's why you'll see in all the definitions of palliative care, families are mentioned because palliative medicine is focused on both. So in that case of a patient with cancer, what are we doing to help the family? What are we, and
mm.
sometimes it's just communication. Sometimes it's talking to them. Sometimes it's lending a listening ear. Um, and just coming alongside them and supporting them. And this is also why palliative care requires a multidisciplinary team, right? This is not something that I, as a paramedic, or someone else as an oncologist, you cannot do it by yourself. Because it's holistic, it requires a holistic team.
Mm.
And so typically in palliative cases like this cancer patient we are discussing, you'll have a social worker, you'll have a minister, you'll have the medical team, the oncologist, you'll have a respiratory therapist, you'll have a psychologist, whatever that patient needs, we put a team together to assist that patient. And so that's also an important aspect of the care.
So there's a bit of your research that is quite hot off the press. So if you can just go through some of the aspects that you found out in your research.
Sure. Well, there's so much. Where do I even start? I've been, this stuff I've been working on for so long. I had to actually, just out of interest, when all of my research finished, the PhD especially, I think it took me 4.5 years or so. Plus, then there was the master's before that sort of had this similar topic.
Right.
I was asked to present my research, and they said, "Oh, you've got a 15-minute time slot." Oh, thank you very much. I don't know how to condense like 8 years into 15 minutes. So I'll try my best. I think probably the best way to go about it is to just go through the journey that I experienced as I went through it. And that will maybe highlight some of the findings. So um, on the master's program, um, the first bit of research I did was interviewing paramedics just to get their views on palliative care. Because at that stage also, it was a growing area of interest worldwide, but really not too much had been done on the topic. So this was very much an exploratory study in South Africa, and it was a very small study. I mean, we interviewed 6 paramedics here in South Africa, um, which was also a research learning thing for me because, I went into all of this stuff wanting to change the world, of course, and have some sort of interventional study, like experimental study, big things, change the system and all of that. And my supervisors thankfully and gently brought me back down to earth and said, okay, well, we have to have a starting point. So we did these interviews. And I think the biggest findings in that study were, number one, that these EMS providers seem to encounter palliative situations pretty often. As much as we are emergency services, we all have so many stories of these kind of patients that we treat. And we know it too. We know that this is a different kind of unique case that requires a different approach, but we don't really know what that approach is, and that's the difficulty. And then the other finding in the study was just that there was 100% support from these EMS providers to integrate with palliative care, to say that, yes, EMS providers do have a role to play in these situations. So it's not a matter of saying, this is not our area of work. These EMS providers were actually quite comfortable to say, no, this is definitely an area that we can play a beneficial role in. So that was where everything launched. So then, moving into taking this further into the PhD studies, the first thing we did was a scoping literature review, natural starting point, and we found at that stage. So this must have been a few years. We finished this a few years after the interview study with the EMS providers. So already in those 3 years, a lot more research internationally had been done. So I was pleasantly surprised to find in that scoping review that I think there were about 52 studies that we included, and most of them recent, within the past 5 or so years. And so really it was a growing area, which was great, because it meant that now even in South Africa, we could contribute to this topic of integrating EMS and palliative care, which, by the way, was the primary aim of the thesis. So yeah, and a lot of the findings there were pretty similar across high-income countries, more resource-constrained countries, in terms of we've got similar challenges, one of which being that EMS provider mindset where we are just curative. And so this palliative comfort care is so foreign to us. So that seemed somewhat ubiquitous across the spectrum of countries where the research was done. And then, of course, that study also opened the door to various gaps in the literature. So what research needs to be done next? And so the way that we approached it in our setting in South Africa was we performed several studies. So we also now wanted to interview palliative care providers, and we also wanted to interview patients and family members themselves to also get their view and thoughts on EMS providers. It's all good and well to say EMS are in support of this, but what are the palliative providers saying? What are the patients and family members saying? So we performed those studies. Then we also wanted to get the quantitative data. What are the numbers telling us? How often do we actually come across these patients? Because again, I can tell you as a provider, in my experience, I come across these patients all the time. But we want to actually now quantify that. How often is that happening? And then after all of these studies, we performed a sort of expert consensus, expert panel, nominal group technique study, where we just brought all of this together. And then that study started formulating a framework for integration, and the final product of all of this was a conceptual framework for the integration of these services. In terms of the patient and family member interviews, and that's the one that is hot off the press. For me, that study was a game changer, just in the way that I approach everything, and I really hope it's helpful to everyone else too. But that just opened up my mind to what these patients and families actually need. And one of the big things that we found there was what we ended up terming the dynamic of control. And briefly, to summarize that, these patients and family members in these palliative type situations with these life-limiting, debilitating illnesses, life sort of began to revolve around those illnesses, which meant that they experienced somewhat of a loss of control over their lives. So again, in other words, I want to go and do something. I cannot do that because, I don't have the power to. I'm too weak. I'm too frail. Don't have the ability. And then, not to mention that sudden symptoms would strike. All of a sudden now you are having a seizure. I mean, that's completely out of your control. That happens. And so they experience this loss of control. And what they wanted from EMS providers was to basically reestablish what control they had left over their lives, bring order to the disorder. Come in there, calm the situation down, sort of transfer the control back to the family so that they are like back, to the best space that they can be with regards to their situation. And one of the challenges was, where they perceived EMS negatively, is where EMS just sort of came in, took complete control of the situation, took the patient to hospital, regardless of their wishes, regardless of if they even knew what was going on. And that's what we tend to do, right? We are trained to go into stressful situations, take complete control. And sometimes that's necessary and that's good. But in these palliative situations, where they saw EMS negatively was the EMS took control away and never gave it back, never included the family members and the patient in the decision making, never helped them to understand what was going on. And so there was this real sense that now I've lost control over my life. Now these strangers come into my house and take even more control away from me. And that's creating even more stress in my life. And so that was a real challenge. And so basically we concluded to say that the EMS providers need to understand this dynamic and seek to let the patients and family members set the tone of the situation. So instead of us just assuming control, let's go in and understand where the patients and family members are at and take it from there. If they want us to take complete control because they don't know what to do, great, then we can do that. But if they don't, if they still want 1, 2, and 3 done, and I still want my loved one to stay home, then let's make a plan to do that. Let's not assume that we know better than the family members. But yeah, that was game-changing for me because it not only changed my practice in palliative situations, but even in emergency situations. Because again, like we spoke about, I'm no longer chasing family members away. I'm trying to communicate with them, understand where they are at, include them where I can. I'm trying to approach patients from a holistic point of view, even in emergency situations. So really game-changing for me.
Did you find anything in your research about kind of misunderstanding of that disease process, and how do patients' family members perceive what is actually happening to their loved one?
We didn't specifically explore those perspectives, but it is related because, and you'll often see this, I mean, in the palliative care literature, it's often you've got two groups, right? You've got known palliative cases where the family, the patient, they are aware of what's happening. And then you have this group of patients and families with undiagnosed palliative needs. So they are not necessarily aware of the disease trajectory. And yeah, those cases are difficult. They're very difficult because, especially from the EMS perspective, because we go there and we might not understand the trajectory ourselves. So we might be just as confused as everyone else. So that's part of the problem. But also, one of the findings that we touched upon was that this is one of the reasons why EMS have a role to play in these situations, is because we are often this first point of access into the healthcare system, right? We have this unique privilege to go into patients' homes, to go into their living environment, to see what they call these days the social determinants of health, and all these different factors that are affecting families. So we get this really unique glance into a patient's and family's lives. And sometimes we can identify that, this patient might actually benefit from a palliative approach to care, whether alongside curative or not. So that's one of the big roles that EMS providers do have to play, is to identify these unmet palliative needs. And so where EMS providers are trained and educated concerning palliative care, they can start identifying those situations and potentially point them in the right direction. The other element of that that's very difficult is the communication. If you're let's say you're an EMS provider, you've identified this situation, the family's not aware. The first
Mm.
question you have to ask yourself is, is it our place to tell them right there on the spot? That that might not be the best idea. It might be better to refer them somewhere else. Maybe just confirm what's going on first.
During the emergency, during the time when the
Yeah.
thing,
Well,
when the patient
exactly.
is struggling to breathe or in pain or whatever the case is.
Yeah, that's definitely not the time to lay a heavy burden of your trajectory is pretty
Yeah.
poor.
Yeah.
So, we have to be very careful. And again, there's no hard and fast rules here, right? We have to be guided by the situational context. And we have to be guided by a person-centered approach to care. Like, this is a human being in front of me. Let me put myself in their shoes in this situation. Is now really the best time to lay all this information on them?
Mm.
Maybe, maybe not. I mean, situations differ. So this is why these situations, like we said earlier, become so complex, because the decision making, for EMS provider, we want to just go in there, give the morphine, and get out, and our job is done.
Mm.
But when it comes to these palliative situations, that can often be harmful. So we have to take these other things into account. But I will say, though, as a starting point for communication, one of the best places you can start is with what do they currently know. So try and get an understanding of what the family and patients actually know. Don't just go in there and share all of your beautiful knowledge with them. Okay, that first of all, you could be wrong, but secondly, that might not be helpful and not what they need. And you might be surprised. They might actually know a little bit more than you about what's going on in their lives. So we have to be careful about that. So just start getting to know them and what they know. You'll also then start getting an idea of how much they want to know and how open they are to hearing from you about what you're thinking. And you take it from there. And again, just bear in
So,
mind that it's not on you in isolation as an EMS provider to completely solve the problems that family is having. No, you're just one piece of the puzzle.
yeah. So, I mean, there is the clinical side, and we've discussed that quite a bit. But there's also a medico-legal and legal aspect to this. What is an advance directive? There's the family's wishes. There's the patient's wishes. There's the healthcare protocols and procedures that we have to follow.
Sure. So there's many different types of documentation, and they've got many different names. You mentioned the advanced directives. There were sort of older documents that were referred to as living wills. There's do not resuscitate orders. There's do not attempt resuscitation. So there's a bunch of different names. Probably one of the most common things these days is an ACP, an advanced care plan. And basically what all of these documentation, what it's all trying to do is to try and be helpful in these situations, to give guidance to family members, to healthcare providers, because they are basically making decisions for a person's care ahead of time, hence the advanced care plan. Because often, especially end stage, end of life, and so on, you are not capable of making these kind of decisions. And so these documents, are legal binding documents that have made the decision already. So for example, if I get to this stage, I'm only interested in comfort care. Please do not put me on a ventilator, those kind of things. So that's just a simple way of looking at it, I guess. Now, part of the problem that we have, at least in South Africa, is that particularly in the EMS environment, these documents actually don't help us much. They cause more confusion and complexity to the situation because we are not, in the first place, really trained on how to handle these documents. The guidance from the Health Professions Council is very minimal for EMS in terms of these documents. So some of them are recognized. And there's sort of a broad statement to say that we should consider respecting them where we can. But, now my EMS protocol is telling me that I must resuscitate, that I must intubate. And also, there is no specific actual legal documentation saying that, no, we must adhere to them. Because emergency situations kind of fall under a different category where we need to perform the emergency treatment, regardless of advanced directives and so on. And so EMS providers tend to default to their protocols than advanced care plans and so on. But I think that's a mistake. And I think this is the one thing that I would definitely like to say on this topic, is that just because there is no specific legal standard to say that, okay, you must adhere to these documents, does not mean that we should disregard them. Because that's typically what's said, right? You've probably heard EMS providers yourself, right? On the rare occasion that you get given a DNR or an advanced care plan, what is the thing that EMS providers always say? Oh, well, that's not a legal document.
Yeah.
And I want to shake my head in shame because so what? This is still telling you what the patient desires. Who are we there to help? The patient or your EMS system? To be honest with you, I get quite passionate about this, but to be honest with you, the EMS system be damned. You're there to help the patient in front of you. We cannot operate in a system-centric EMS service. It must be person-centered. So, and I'm quite glad, I got the opportunity to look at a course that's coming out pretty soon within the next couple of weeks concerning EMS training in palliative care. And one of the things that is emphasized in that course is to say, guys, where you do see an ACP, a DM, whatever is relevant, do your best to adhere to that. Do your best. And to give some confidence to providers who are gutsy enough, I suppose, to do that, you will be covered. It's the patient's wishes, written in black and white. You can easily defend yourself by going there in the best interest of the patient and performing as a good Samaritan and doing the best that you could with the information that you had. You will be covered. And so it's important for us to take that into account. So as much as in South Africa, to summarize, they are technically not legal documents, they are still documents to be adhered to.
Yeah. And I think there's a difference between, and I must go back to the terminology, but a do not resuscitate order that's been written by a healthcare provider, as in all of the treatment that we've done for the patient it's not curative anymore. We're going on to palliative only type of treatment. And then you get
Correct.
the patient's wishes, those kind of, I do not want to be resuscitated. I was used to teach this to my students, and I always used to say to them, maybe this might not be legally blinding, this document that you've been handed by the patient, but as long as that document aligns with the patient's wishes, which you can perceive, you can always perceive what the patient's wishes are, and obviously your own clinical judgment, then you are, at least from a legal perspective, but at least there you are covered because your clinical wishes are the same. And we always throw in these like ethical or ethical scenarios that, what happens if a family member comes to you and obviously they've just clearly murdered their family member, and they said, do not resuscitate this patient. And then obviously the wishes of the patient is not aligned with your own clinical judgment. So I think
this is the thing,
that wouldn't happen often,
Yeah, and this is the thing. It's still, these documents don't absolve you from applying your mind.
Yeah.
Because also there are situations, and this is what becomes complicated in palliative care as well. Patients can have these advanced care plans, I don't want to be intubated and put on a ventilator, let my cancer take its course kind of thing. But now, we get to that patient is struggling to breathe, and we find that it's from an acute event of anaphylaxis.
Yeah.
Do we not treat that then? Because now it's
Yeah.
a separate disease. So we still have to apply our minds. You must still treat the anaphylaxis, so,
Yeah.
and if that patient ended up intubated in that acute moment, that wouldn't necessarily be going against their advanced care plan and what they had in mind.
Anaphylaxis is an allergic reaction, a very severe allergic reaction for those of you that are not medically
Yeah.
trained. But it's a
So,
different disease pathway than what would be deemed the terminal illness.
yeah, yeah. So, there was even a case when we were interviewing the palliative care providers. One of them shared with me a very interesting story. So they were with a paramedic uh, at an incident, a end-stage palliative care situation, with a paramedic. And the paramedic had been trained in palliative care. And so the paramedic was kind of like, look, we've just managed the symptoms here. We're going to leave the patient at home. And surrounded by family with home care palliative support and so on. But it was actually the palliative provider who recognized that, no, this is actually a different emergency. We must go to hospital. So it was the palliative
Right.
provider that then said, no, we're going to hospital. So very interesting. So we do have to apply our minds. And again, it just shows the benefit of working with a team and
Yeah.
not making these decisions on your own. Yeah.
No, absolutely. And I think there is one, kind of the last aspect that we're going to speak about is euthanasia. We didn't go over this before, so I really don't know what your opinions are. I've obviously got my own opinions. It's becoming, if you just look around the world, becoming more popular. Um, or it's becoming legal in more places. I think South Africa is just I might just say I don't know, but I think it's become legal there. It's obviously legal in Switzerland and a whole bunch of places. Um, so just give me your ideas on it, and maybe I'll share mine as well after yours.
Sure. So I think when thinking about the topic of euthanasia, it's probably also good to just start off by just perhaps defining the terminology a little bit, because there is a distinction that has been made, but there is a distinction that is made between active euthanasia and passive euthanasia. So, so passive euthanasia could be a situation where, let's say, according to someone's advanced care plan, you withhold life-sustaining treatment and you let the disease take its natural course. So that would be passive. In other words, we're not actively intervening because we recognize the trajectory here is quite poor and this patient
Mm.
is most likely going to die. So
You're
that could
not.
fall, even that something like that could fall into I suppose, the broad category of euthanasia, but more specifically, passive euthanasia. And then
Mm.
there's the active euthanasia, where we are actively administering a harmful substance to cause the end of life. So I think those two situations are a bit different. I'm going to primarily speak on my views on active euthanasia,
Mm.
because I think passive euthanasia, if that's what we want to call it, is sometimes acceptable, maybe sometimes not in poor decisions, but it's very much situation dependent. So in my mind, it's sort of a separate category of discussion. So when I talk about it, I'll be approaching it more from the active, like we are administering a substance to cause death, uh, essentially. And I also, a couple categories of discussion on it. I think I'll start with what I would call in the scientific realm. And in the scientific realm, I'm very hesitant about euthanasia because of many reasons. But fundamentally, it seems to me that euthanasia is an unscientific endeavor. And the reason I say that is because science is based upon observation, right? Now, this is one of those treatments, if we want to call it that, euthanasia, that we cannot follow up on, at least not from the patient's perspective. You know what I mean? We cannot observe what happens to that person after death.
Mm.
Now, obviously, now we get into big philosophical debates and discussions and things, but that proves the point, doesn't it? We're now outside of the realm of science. We're outside of the realm of what science can tell us. So now we have
But
to, now we have to, yeah.
there are aspects of our treatment that we have, or the way that we operate, that is not always backed up by evidence.
And
So we
that is true.
can, there's a psychological part, not to say psychological is not scientific. But like
Well, there's a lot of it
now about
that's another discussion, but there's a lot of it that's not scientific for sure.
Yeah. So not to bash the psychologists, yeah.
Yeah, no.
Yeah, even as part of our management, we will have, like we spoke about now, with the family members. So I don't think there's a lot of necessarily hard science to it. We need to kind of go into the more philosophical, ethical aspects, and there are some things that we won't get answers to in science. So I hear your disagreement with it being unscientific, but that's an answer that we're not going to get from science. So is it an answer that we can get from philosophy or from ethics?
Yeah. Well, and so what conclusion do I draw from this? It obviously doesn't make sense to draw the conclusion that because something is outside of the scientific realm, it is necessarily wrong, right? That argument doesn't follow. So there's no argument to be made there. But what I do push back against is this idea that this is a scientifically, medically, academic type of treatment, because it is fundamentally not. It cannot be, pretty much by definition. And so I think the conclusion that I draw from this is that it is important for us to recognize that, and to recognize that we are going into an unknown realm here that we can only philosophize on, right? So that's sort of, I'd say, a big concern with in the scientific realm. The other one is that, and I mentioned earlier that it doesn't form a part of palliative care, and that's true. However, these days there are a lot of people speaking about it under the palliative care umbrella.
Yeah.
I also want to caution against that. The reason being because one of the reasons that palliative care is so underutilized, and that most patients with palliative needs don't have palliative care, don't receive palliative care, is because they're so hesitant about it, because they don't believe in euthanasia. As an example, so like in South Africa, for example, don't believe in that, in euthanasia. It's wrong. We don't want to be a part of that. And now we put that under the palliative umbrella, and so now people don't want palliative care. And that's so unfortunate, because we have such palliative care needs and burdens in the country. So a plea to everyone out there, please keep the euthanasia discussion separate, because you will undo so much of the good work that we do in trying to dispel these myths here. As soon as you link it to palliative care, you're going to lose half of the world's population, if not more, because no one's going to be interested, and we're going to make these connections in our mind. So that's also something that I warn against. I think it needs to remain a separate discussion from palliative.
So, but where does that discussion come up from? Because if you have a palliative care person that is treating the patient, where else does that discussion come in? If it is, say, legal in the place that you're treating patients.
Yeah. Well, maybe that brings me to my next category of things. Because in my view, the conversation should never come in. Because so in my mind, now that I've established that this is not a scientific thing, this is not something that science can answer for us, we are now in the philosophical, religious realm, if we want to call it that. So from a Christian worldview, I would say that active euthanasia is wrong. Uh, and I, I go further and say that it's morally reprehensible. And that's because of the value of human life. Um, so uh, in Christianity, in uh, the biblical text, um, humans are created in the image of God, and that's what gives them fundamental value. And any sort of attack on that image um, is an affront, an attack on God Himself, and so that cannot be done. So in biblically speaking, active euthanasia would fall under the simple category of murder. It's premeditated. It's something that you've done to cause an end of life. So it would simply fall under that category. Yeah, I'll leave it at that for now.
If you have talking about like maybe outside of the religious aspect, because I know a lot of people would say, I don't want my justification to come from the Bible for certain things. So if you say, if we go to the legal aspect, you have a right to life, and that's, I mean, it's actually written down in the South African Constitution, and it's written down in almost every single constitution there is. Obviously, you have the right to life. So, and obviously that's why murder is illegal. But if you have the right to life, why don't you have the right to choose when your life is over, or when you no longer want to live that life?
Yeah, and so to be honest, I think even in the South African Constitution, right to life, it all depends on how you define that, right? It depends on what situation. So the South African, even with the current constitution, I'm pretty sure they could find a way to make it legal if they wanted to. Because with all of these things, it does depend on how you phrase it and define it. From my perspective, and this is why I find it very helpful to have a Christian worldview as a standard, is because that is the basis from which morality comes. Because now we're talking about a moral discussion here, right? That's the realm that we're in. So that's the basis of morality. So for me, if you take that moral standard away and we say that there is no moral standard, yeah, then go for it. I mean, do whatever you want. I would argue that if you take that standard away, everything is sort of fair game. And I know, I know that's a big thing that people discuss as well. But my question is always, so if we have sort of no moral standard that's outside of ourselves, right? That's external to us. By what standard do we make moral decisions in the first place?
There's a study of moral philosophy. So to say that if it's not within a religious context, doesn't mean that there's not morality or ethics. I mean, if you look at Sweden, for example, it's got one of the highest rates of secularism, but they are, I would say, incredibly moral society. So we don't necessarily need to have one with the other. If we could say, if you were the one in power and you could snap your fingers now, would you? I mean, obviously, I can hear from what you've said before. Would you say yes or no to euthanasia, make it legal or not,
I think
and your reasons for not?
I think in
I'm
the first
assuming.
place, I know this is hypothetical, but I think in the first place, I would never want to be in that position. But yeah, I mean, I would, from my view, I would say no. One of the big arguments I think behind it is also an argument from compassion. You've got people who are really suffering a lot, and there's nothing you can do about their suffering. It's intractable. And that is a real problem. And that would pull at my heartstrings and cause real problems for me, especially if I was in the moment there to see. So that's the other thing I just want to maybe say is that it's easy to have these kind of conversations sitting here and not actually confronted with it in the room. That with that being said, my worldview would not allow for it. But also, I would say that even if we just take a brief snapshot of history, just because something is done out of compassion, it also does not logically follow that it is therefore right. When and where and what are the criteria for the patients that receive euthanasia? And how far do we take that? What kind of suffering are we talking? Does it extend to mental suffering?
I'll give you my opinions. And I think that there are aspects of the legislation that you could probably get right. You could make certain criteria. I think if 18-year-old comes to you and says that they want to end their life because they are clinically depressed, I think in a society that would put that person or adhere to their wishes, I don't think that's right. But as you said yourself, like putting yourself in that situation where your family member is in extreme suffering, it was like a horrible way to die. So I think in those cases there is maybe a gray area where it may be moral and ethical to do that, to go along with their wishes. So I think there's and then there's the aspect, obviously, that that person has their own wishes. And I think maybe we need to respect that. But that being said, as a healthcare provider, I would never be the one, that would perform that procedure.
Can I maybe, before we close off, can I maybe leave you with a couple thoughts?
Yeah.
So, you say, for example, that the 18-year-old with the mental illness and so on who wishes to end their life. I would just ask again, if there is no external moral standard, what makes you draw the line there? And why should it not be drawn somewhere else? Why should they not have the right to death, but someone else gets the right to death? So when we don't have this external standard, it becomes very tricky. We have to create our own standard. And then the final thing is that I mentioned, that we cannot observe directly what happens after death. So again, we are doing this in the name of relieving suffering. Who's to say the suffering ends? I can't observe that. So it's this outcome that we have in mind that is not measurable. And I think that should give us a bit of pause. Regardless of what you believe, it should give you pause that we're chasing this outcome that is not measurable. And that's a problem. Yeah, I'll leave it there.
Well, we'll leave it for our viewers to decide.
Yeah.
Thank you so much for your time and your great work that you've been doing, researching this very, very important aspect of not only EMS care, but healthcare. So we thank you very much, and it's been great having you on.
Thank you so much for having me. Really appreciate it.